Hey, good morning, and welcome to the euronurse.com. I'm your host, Vic Sinise. Glad to have you on board today. If you're watching us live, great. Be sure to use the comment bar to go ahead and put any questions that you might have in for our experts today. Also, if you're on YouTube, be sure to hit that subscribe button or that like button. Always need to have the help. This is your first time joining us. Be sure to check out our website at euronurse.com, the best place to go to find out more information about the show. It's also the best place to go and check all of our past episodes. We've got 83 of those episodes for you. Hey, want to listen to us in your car? Why wouldn't you? Check out our audio podcast. It's available through the EuroNurse Plus area. You'll be able to go to any of your favorite areas to go ahead and get that and join it. If you're not getting our newsletter, why not? Go ahead and go to our website and just sign up. It goes through MailChimp, so nobody knows your email. It's just a quick and easy way to learn more about the show. This week, we've got our experts, Russ Hansen, a registered nurse, and Rod McComber, a radiology technologist who own an ESWL service. They're going to be talking about breaking the traditional role of a physician-owned practice. So we're going to go ahead and bring in our experts right now. Experts, welcome to the show. How's everybody doing today?
Good morning.
Good morning, everyone. So we'll do our introductions. I'm Vic Sinise, as I mentioned earlier. I'm the host and producer of the show. Been involved in urology for the past 40 years, and this is my way of paying it forward or backwards, however you want to look at it. We're glad to be here and to bring in new and exciting information. And with that, I'm going to bring Lori in next.
Good morning, everyone. Good to be here. My name is Lori Atkinson. I'm a certified urology registered nurse. I've been in urology for 25 years. I can almost say 26, but not quite yet. I work for a urology practice in Geneva and Winfield, Illinois.
Great. Welcome to the show. John, go ahead and give us your introduction.
Good morning. I am passionate about helping urologists succeed so they can reach maximum clinical and financial success. To that end, I created the Urology Practice Facebook group, the Thriving Urology Practice Facebook group, where we crowdsource practice management solutions for everyone's benefit, and it is all for free. I frequently speak on the topics of coding, billing, revenue cycle management, marketing, and how to run your practices more efficiently in the area of declining reimbursement and rising practice overhead. I'm John Lynn, a private practice urologist in Gilbert, Arizona, and I look forward to our discussion today.
All right, great. Rodney, you're next. Give us an introduction.
Good morning. I'm Rod McComber. I've been involved in urology and ESWL since 1997, and I've worked on probably 10 different lithotripters over my career, and been involved in ureteroscopy, laser lithotripsy, and also ESWL. And I'm the co-founder with my good friend Russ Hanscom of Bedrock Lithotripsy. So we appreciate you having us on very much.
Yeah, we appreciate having you here. And then last but not least, Russ, go ahead.
Hey, good morning, everybody. And for those tuning in later, good afternoon, or perhaps if you're watching in bed as you fall asleep, good evening and good night. Rod cut himself off a little short. Rod's been doing it for 27 years, and he's either fragmented about 9,000 stones using shockwave lithotripsy or have been involved in laser lithotripsy for about 3,000 procedures. So altogether, over his career, he's fragmented or participated in about 12,000 kidney stones. So he's the real content expert. I'm Russ. I've been a registered nurse since 1987, and I received my master's in health administration from the University of Washington in 1991. My real passion has always been to improve patient care. I don't do this full time. I work part time on Bedrock lithotripsy. But again, once Rod described the business model in the Pacific Northwest that he was working on and some of the challenges that he was experiencing with his employers, we decided in the summer of 2017 to give it a go to see if this could be something that we could prove a concept on. I'm happy to say after about 6 years, it seems like our proof of concept has come to fruition, not without its challenges.
Great.
Yes?
Yeah, go ahead. I'm sorry.
Okay, sorry. Our primary objective today is really putting the patient first and to educate patients and really the general public and all the various healthcare professionals involved in kidney stone treatment that really there are essential elements that make shockwave lithotripsy just as effective as laser lithotripsy, with clearly shockwave being a much less invasive, actually a non-invasive procedure, while laser lithotripsy really is invasive and composes a lot more serious complication risk factors. So we're excited to bring this story and our data to the public.
All right, great. And you weren't so far off wishing some people, whether they're sleeping or waking or whatever, because we are actually picked up in 31 countries. And I know one of our live viewers comes in from Australia. So I think it's like 1 a.m. for her. So you never know. All right, let's go ahead and bring in the show here and take it away.
Well, we've been 99% successful, and we've defined our success by not needing a second treatment. Now, we're not data scientists, we're not academics, we're healers. And the data that we're going to bring you today has its limitations. There are holes in it. There's some data that's missing. So it's not perfect, but it's our data that we've experienced in the first 4 years of our business. So we're highly confident in our success rate, even though when we discuss our data, you'll see, oh, you didn't collect that, or you didn't collect that, or you didn't verify from a secondary source this many. And we'll discuss as we go through the slides, that is the limitation. Your turn, Rod.
Well, I almost fell asleep during Russ's introduction, but at least now we're back on task and moving forward with our slides. And I did notice that Russ's eyebrows are, in his emoji, are perfectly black. I'm not sure how he was able to achieve that.
Okay, I don't know why are you doing this now?
Anyway, let's just move forward with the important data. The technologist is very important in the success of the procedure. The physician is the one that brings us excellent candidates, and that we believe is paramount in adding to our success rate. And we'll move to the next slide.
Well, hold on just a sec, real quick. In validating our success, Rod would document, and he'll show you on the next slide, what defined success. So he would document, but self-reported is self-reported. So one of the real limitations in our data is getting that secondary validation from the treating urologist. And the difficulty with getting that validation is we only could rely on, because getting a hold of a urologist just to say, hey, did it work? We relied on the second time or third time that we saw the urologist to say, hey, did it work last time? So even though we self-reported success 99% of the time, we had to ask the urologist, hey, we're pretty sure it broke, did it? And the confirmation would happen anywhere from 1 to 3 weeks to several months. So clearly we were a lot more confident in the secondary validation from the urologist several months later. So Rod will discuss on the next slide how he knows when a stone breaks up.
Yeah, it's very challenging to know, and since we don't see the patient in a clinic setting in follow-up, oftentimes they're asked to strain their urine to see if they're passing fragments or not. In this slide, the top series of 4 slides here, we have a double pigtail, double J stent that's been inserted. And you can see the stone just to the lateral of the stent, and you can see that the stent is on end. And as we begin shocking and start having some success in fragmentation, you can see how the stent actually twists in the kidney area, and the curl of the stent is in the renal pelvis. And as that stone starts to fragment, you can see by the 4th slide not only a loss in volume and density, but you can also see that the stent is actually twisted now, and there's been room made in the collecting system for that stone or for that stent to start making the twist. And that's a perfect example of just of a validation that you're having amazing fragmentation success. The lower two slides is obviously not a stent, but you can see the density of the stone on the left, and then the decreased density and the loss of the formation of the stone on the right slide. These are just two examples of the 770 some that we had in our initial study in the first 4 years. And sometimes the stone breaks beautifully, and sometimes the stone doesn't appear to break at all until the patient gets up and starts moving after the procedure is over. And so I've been fooled both ways, where I think I've had amazing success and it didn't work so great. And then you think that you have had poor success and it worked perfectly. So it's a very tricky thing to distinguish and perfect, which is what we're trying to do.
So here's the data. It comes from the first 4 years of our being in business. You can see it's been about 200 stones a year, which makes it pretty difficult to stay viable. Really, 400 stones a year would be a lot better for our business and for Rod's salary. But although we did 764 cases, we were only able to verify with the physician 700 of those 764 cases. The real strength of our data is we don't refer the patients to our business. So it is complete random, a collection of random patients from 42 different physicians at 27 different sites. And you can see here that the female and male breakup is comparable for the most part. I'm going to preempt Rod. He usually has a great 1980s joke here about the differences between females and males, but it's not 1980 anymore. We've been friends since the early 80s. So sometimes we regress back to the 80s humor, which really isn't appropriate for this day and age. But looking over at the demographics of the age range, really after the age of 29, it's pretty evenly distributed with the ages that you see there between ages 30 and 50, 51 to 64. And then we focused on the Medicare age of 65 to 94. Like I said, our experience has been it's kidney stone disease after the age of 30 is pretty evenly distributed among the different age groups. Anything to add there, Rod? Besides a joke that I made sure you didn't tell?
No, I think we can all agree that women have a much higher pain tolerance than men. We'll just sum it up with that.
So what was the rock situation that we discovered? About 80%, 83% had one stone. And as I was preparing this last night, and the slide was already done, and I had difficulty going back to finding our raw data. Really, the average size in the kidney and the average size in the ureter is a bit misleading. The better statistic would have probably been the median, which you rank from the smallest to the largest, and then what's in the middle, or mode, what happens the most. And you'll see from the next slide that in all likelihood, the more common, not the average, but the more common stone that we fragmented was between 4 millimeters and 8 millimeters. And Rod will explain that slide a little bit as far as what the sizes look like. But you can see here that it's roughly 3 to 1. We'd love to share our data with other national companies or even local companies as far as what do you see? Because for us, for every 3 cases we have in the kidney, there's 1 case in the ureter. Unfortunately, because this is what I was talking about, our data is real world. Sometimes we just miss documenting where that stone was located. But that's 125 cases out of 764, well, 700, sorry, out of the 700 that we used in communicating our success rate, because we weren't able to verify the other 64 cases, that we just didn't document where it was located. But we feel pretty confident with a number of about 600 cases that trend of 3 to 1 would remain the same. And a very, very small percentage, I think it's like 0.007% or somewhere 0.07%, had stones both in the kidney and the ureter. Rod, you can talk a little bit about this slide.
Well, I think what this slide basically represents is the majority of our patient selection is appropriate because the size from the 4 to the 9 millimeter size stone is the one that is most likely to cause pain and obstruction. And the larger stones that are too big to try and go down the ureter, they obviously will need either staged treatment or an ESWL with a follow-up laser procedure. And so it's encouraging to look at the data, and sometimes it gets kind of boring and your eyes roll back in your head, but a lot of times it does validate that the physicians that have utilized our services are choosing perfect candidates. And we ultimately need to deflect a lot of our success to the proper patient selection. And the data here with the 4 to 8 millimeter stones, these are stones that could be a problem. And sometimes they do what's called a ball valving type situation where the stone will drop out of the kidney and into the ureter and have a partial obstruction with a pain episode. And then the stone will pop back up into the renal pelvis and the patient will not be obstructed and all of a sudden have no pain. And so that kind of is validated here. A lot of times the stones that are smaller than 4 millimeters, they may not necessarily obstruct, or they may partially obstruct and be able to be passed on their own. And a lot of times if they do drop in the ureter, the physician will choose ureteroscopy and laser lithotripsy as a better viable option. So that's obviously their prerogative to make that choice with the patient and their consent. And I just feel that the data that I've read about is that shockwave lithotripsy is ultimately better statistically achieved in the kidney itself. Ureteral stones, the statistical data is less impressive on shockwave lithotripsy in the ureter. So that's kind
especially when it's distal. The proximal ureter stones, I mean, we had about 20% of our cases were in the ureter, and I can't think of any of those stones being in the distal ureter. But again, we missed 125 cases where the location was, but because Rod visually verified the fragmentation, we still believe the 99% is a very, very solid number. I did want to just briefly mention why we called out a multiple stone load greater than 20 millimeters. That is an AUA guideline that shockwave lithotripsy may not be ideal to use in this scenario. And it does represent an incredibly small number of our cases. Again, part of our reason for doing this webinar and starting to tell our story more is we want to be the benchmark and we want our data to be challenged, and we'd love to start sharing with other companies so we can all drive more patients that are appropriate to shockwave lithotripsy. And Rod may address why shockwave lithotripsy might be falling out a little bit of favor with some of the new urologists, but we want the general public and kidney stone patients to know that shockwave lithotripsy really is an excellent choice. And Rod has always said, we believe nearly every stone is an ideal candidate for shockwave lithotripsy. So the 6 failures that we were able to document, based on Rod's kind of like, I don't think we did this one. And then the urologist clearly saying, yeah, guys, we didn't nab that. 4 had a laser. And then on the right side of the slide, it is the same patient, and Rod can, there's 2 patients, and Rod can discuss why laser versus shockwave was decided on the follow-up treatment.
Well, the troubling thing about this slide is that my character is falling, and that's, I don't know if that
But
was.
You're still smiling.
I don't know if that was intentional or not. That's the failure, but the 2 stones on the right, obviously, it was a staged shockwave lithotripsy treatment, so wasn't considered a success. And this is Russ and I have debated this for the whole 7 years that we've almost been in existence. But the stone was reduced in size almost by half in both of these patients, but a second treatment was required. These patients did get a second as well. The ones on the left, the urologist opted for follow-up with ureteroscopy and laser lithotripsy to make complete stone clearance. And so that kind of explains that.
Well, but why was laser chosen over shockwave? Why didn't we shock those?
Well, that's the physician's choice, or the patient's choice. And you know, my feeling is on a distal stone, the access and the invasiveness of the procedure is much less than having to drive a ureteroscope all the way up into the kidney. Whereas if it's a distal stone in the distal ureter, it's a very simple entrance to the ureter, laser lithotripsy, and then you know that you have 100% success with minimal risk. Where if you shock a distal stone multiple times, when it could be treated with a laser and get that stone out 100% of the time, now you're not needing a second procedure. So
no, it doesn't.
Okay.
Because does stone composition maybe have a influencing factor?
Oh, sure. Yes. I'm sorry. Yes, absolutely. And that's one of the unknowns when a lot of times when you're getting ready to do an ESWL, nobody really knows what the stone composition is on the first stone. If this is a patient's first event of colic, and they haven't had fragments to be analyzed previously, stone composition absolutely can make a difference, and especially if the stone is in the ureter where you're statistically less successful. If the stone composition, which is the unknown, is a very, very hard stone, then it just might not respond that well to ESWL. So laser is the definite better option for that. Thanks, Russ. Sorry about that.
Yeah. No, you're welcome. So before Rod starts talking about the appropriate patient selection, I just have to say this is where, enduring 6 years of litigation, even though we truly believe everything that we said and did was transparent and truthful, sometimes truthful statements can still spend a lot of money on litigation fees. So we might get some direct questions about this that we might be a little bit reluctant to answer. But that doesn't mean to say that we might not answer it in the future, but we're going to proceed with a little bit of caution through this. So Rod, if you want to talk about why the location really does matter in the appropriate patient selection that docs have given us.
Sure. Well, I think I addressed a lot of it in the last slide, but what's required or what's helpful in the shockwave procedure is space and an area for a cavitation effect during the fragmentation for the stone to actually have room to start expanding. And as part of the shockwave, the reverberations and the pressure points where the shock waves come in to do the damage to the stone. In a cavernous scenario like the kidney, you have a great option for expansion during that process. in the ureter, it's the stone is being held in a very tight environment, and there's not room for expansion necessarily. And so this is why the majority of our patients that have been selected by the urologists that utilize our service have chosen, the majority of them have been kidney stones. And it's offered by urologists many times for multiple treatments because it is less invasive. And a lot of patients, when you are given that option to choose, will choose the less invasive one. If we can get rid of the stone without you having to instrument me or drive anything into my ureteral system, that's an easy sell. And so that's a lot of times as patients become more aware of their options now by just Googling, I've got a kidney stone. A lot of times they will go to their urologist and say, I don't want a stent, or I want ESWL, or I want ureteroscopy and laser lithotripsy. And so as the public becomes more aware, which is what we are trying to do, is make people aware of their options and the statistical outcomes.
So Rod's spot on. More than anything, patient selection has probably been the predominant factor in our remarkable success. And he also has a great example. If think of a kidney stone like a tennis ball, if you put a tennis ball in some pantyhose, there ain't no room for it to jiggle and to expand that break. So in the past, we believe body mass index, which also influenced skin to stone distance, mattered. But we have, because we're 99% successful, and we've had some really pretty big folk that Rod has shocked successfully, the technology has really advanced and eliminated BMI or skin to stone distance. So we're very proud and very honored that we were selected to have the first upgraded technology in 13 years. And so let me advance to the next slide. We did purchase the very first Dornier Delta 3 in the world. It felt a little weird, but it was a great marketing sell to the urologists who were wondering, okay, what are these guys doing now? This is very different. But because we had the most advanced technology in the world, our first cases were done in a small and beautiful town called Newberg, Oregon. So, Mr. Vic, if you could pull up the video, we'll play the video, and Rod can talk about the advantages of this machine and the benefit to the patient.
Well, you just saw it roll through your screen. You could pause it there or pause it here would be great. Yeah, thank you. This is a traditional X-ray C-arm, and the shock wave a component to it is in the middle there. So people always say when you're wheeling it in and out of the hospital, what is that? What is that machine? What does it do? It's an X-ray and ultrasound machine, with the ultrasound being the sound wave that's generated, and it's generated by the suction cup looking device. And the C-arm obviously is a mobile fluoroscopy that is used to locate the stone. It's able to go 30 degrees to the cephalic and 30 degrees to the caudal. And then this is the monitor cart that you can actually see the images. And so these are made by Dornier, who is the original inventor of the technology. And in my opinion, makes the most amazing device. And they've just continued to advance this technology and do things to make it more user-friendly and to make it more efficient. And those are the two things that are that they've just continued to advance it to make it more tech-friendly. Yes, Rose.
What's the image on the right?
There's an ultrasound image on the left screen as it's facing you, and the right screen is a fluoroscopy image. So they have the ability to either look, and there you can see the ultrasound transducer there. So you can also look under ultrasound guidance. That's an option. This is the therapy head that's expanding to meet the body style habitus. And if you can pause this right here, the shock waves are generated in the lower portion of the in a coil scenario, and then they are focused at a point out in space. And that is what you see, the little dot where the sound waves are going out. And so where the body meets where the skin meets the bellows of the device, that is the entrance area, but it's not where the shocks are focused. The point out in space, which is inside of the patient. Here you can see the cutout in the table where it comes up under. The patient can stay supine. Here you can see they're applying the coupling gel. And this is a new feature that Dornier has. It's called the OptiCouple. And you're able to clear all of the air bubbles out because air bubbles impede the efficiency of the shock waves. And so you have a clear view of that you have perfect coupling, and your efficiency is improved with this device by 40%. Phenomenal, which is a huge number. And you can see that we're able to treat anterior. The shock wave comes over and comes down over the patient. So if you have a patient that is too big to reach posteriorly through the stone skin distance, you're able to flip it over and treat them from the front. You can see the two half moon cutouts where you're able to pull that out and drive the device in. And this shows that the machine is very portable. And so you can pack it up and go to the next hospital the next day. It's a very glamorous life. Yeah, it's a phenomenal device. We're honored that Dornier has let us try and prove how successful shockwave lithotripsy can be. And we have 2 of these devices in the Northwest.
So again, just to reiterate, the focal zone has increased significantly, and bubbles really do matter, like Rod mentioned. If there are bubbles and there's not a good, correct me if I'm wrong, coupling,
yeah,
that affects the sound waves. And previously, before these portable machines, to make sure that there was a good coupling, patients would actually sit in a bathtub, and it was done in a tub of water. Last, but certainly not least, is so we have appropriate patient selection, we've got phenomenal technology, but really the person doing the procedure matters. And we're trying to come up with a new certification mark. We'll see how successful we are over this next year as we begin to tell our story. But we believe that there should be a carve-out with the American Society of Radiology Technologists for people who do perform this procedure. And so Rod will just really highlight what he has found to be tricks of the trade in making sure that the technologist has the knowledge and the experience, because from what I've heard and what I've observed with Rod is that it really is a science. But like with any successful medical procedures, there is some art sometimes. So Rod will cover very humbly. He is one of the most humble men I know. But really, Rod, this is your turn to talk about your 27 years of experience and the tricks of the trade that you've come across that has driven the 99% success.
Well, it's when you're sent to an environment to do a procedure that you don't have a lot of continuity with, there's always uncertainty. And in a stressful environment like the operating room as it can be, if you already feel apprehensive by not having experience doing the procedure, then it's even a more daunting task. And so it is something that, just like getting out of the shower and toweling yourself off the exact same way every day, or brushing your teeth in the same pattern every day, it becomes there's a lot of it that becomes very habitual. But there are certain things that you can do that help you find the stone, and that's what's so tricky about it. A lot of times, if a stone appears very dense on X-ray, then you just wheel the machine in and you can see it immediately. That means that's a pretty hard stone because it shows up well on X-ray. The tricky part of it is trying to find stones that are not easily visible on X-ray because of their component. They might be a uric acid stone, which doesn't. A uric acid stone shows up perfectly on a CAT scan, but on a standard fluoro or sometimes a KUB, which is a kidney, ureter, and bladder static X-ray, all of a sudden the stone doesn't show up as well. And so there are certain things that you can do to try and be able to target that stone. And the reason why that's important is because if it doesn't have great density to be able to show up on the X-ray, then that means most of the time it's going to respond very well to shockwave because it's not that dense. So all we need to do is deliver this vibration and this energy, and that stone will just melt away. And that's the very hardest scenario, is finding the stones that don't show up that well, because we know that given the proper energy delivery, they're going to be an excellent outcome. And so there's all kinds of little tricks and trades that you can learn. That's not something that people want to hear necessarily and go over, but I geek out on it because I have been doing it so long that it's a very gratifying and satisfying career for me. I no matter what, I love doing these procedures, and I think a lot of other techs enjoy it as well. It's a great chance to have a good camaraderie with your surgeon and establish a great rapport, and I love that part of it. And they really do put their trust in you, and we don't take that lightly at all. We're very honored that they choose us and that they entrust their patients to us. And
all right.
Yeah.
Rod and I, when we rehearsed a couple days ago, we're like, we'll be done in 15 minutes. And here we are at 37 minutes. So
oh, boy. Sorry.
I really appreciate your patience to getting to the questions and answers, because we're excited to hear what the curious folk might have about our experience. We're ready for questions, Vic.
All right, let me bring in our experts here. Thanks for the great talk on that. We have any questions from the audience, first of all, Lori?
We do have one question. I think it was answered after she had posted this, but if you would just repeat, what determines if a patient gets an ESWL versus a laser lithotripsy?
Well, Dr. Lynn can probably address this better than I can, but with patients becoming more knowledgeable about it, a lot of times they will request one or the other, or sometimes they will actually shop for a doctor that won't give them a stent. But a lot of times it's up to the provider and the patient to have that discussion to determine what is the better outcome, what gives them the best chance for an outcome. And so sometimes the physician will suggest it and the patient will go along with it, or sometimes the patient wants to find somebody that will give them shockwave instead.
Okay, very good. I have a question to ask. So the difference is, I mean, I think most of us realize that most of these shockwave systems are physician owned or maybe hospital owned, but this is a unique situation where RN and a radiological technician own the equipment. So how does that change the scenario? Because you still need a urologist involved. I know you were talking about your better results. Again, how do you drive better results? Is it still the urologist's decision on which cases should be done, which shouldn't? So either one of you want to comment on that?
Sure. Yeah. Look, we were pretty nervous, but Rod wanted to leave his employer and continue to do lithotripsy, but there was no other company to go to. So yeah. The only way to leave his employer and continue to do what he loved to do was to start his own company. So competing with physicians that own their own machines is a challenge. But we've always been open to physician ownership. And that's been a little bit misconstrued in our region about what our philosophy is. So first, we had to prove the concept and implement a business model that really drove excellent patient results. And now that we've done that, we're going to be very open and seeking out some physician partnerships, because really they do add clout and validation to the company. And
Of course.
as you can, it's been a challenge. I don't think it's insurmountable, but there have been physicians that have continuously used us for 6 years, and they've been part of our remarkable success. So we're looking forward to what the next several months might bring regarding physician partnerships. But we're eager to start looking at that and starting to have those conversations.
Yeah, just to add to that, we have noticed that there's been a shift in the Northwest anyway, that physicians that are being employed by the healthcare facilities, and in that scenario, a lot of times they're not allowed as an option to be an investor, and so we thought that might be a niche market that we could tap into. So,
yeah, we also want to push. We also want to push the envelope that physicians really should own lasers. When Medicaid decided, or CMS, the Centers for Medicaid and Medicare, decided that shockwave lithotripsy isn't a designated service, but laser lithotripsy is a designated health service. I'm still, I'm kind of an expert on Stark law and the workarounds. And to me, I still have not heard of a good reason clinically why shockwave is not a designated health service, but laser lithotripsy is. So not only have we pushed the envelope regarding ownership, we with a nurse and a radiology technologist, but we really are going to be challenging that. We believe physicians should be able to own lasers.
Good. Experts, any questions?
I do not have any questions. Thank you, guys. That was great.
Hopefully that means we were thorough enough.
John, anything to ask?
Yeah, I just want to point out that fragmentation, a subjective evaluation on fluoro of fragmentation does not necessarily mean success, because you have patient factors to take into consideration. Every patient's anatomy is different. Some patients can pass easily a 3 millimeter stone without any sequelae or symptoms. However, I have had to go in and ureteroscopically remove a 2 millimeter stone stuck at the ureterovesical junction. So the definition of success needs to be much better clearly defined when you claim success, 99% treatment success. It's first of all, there seems to be a lot of subjectivity involved in this success. So that's why maybe certain institutions may be reluctant to claim success in the scenario that you are describing.
Yeah, it's an excellent point, because there are a lot of patients that can pass 8 millimeter stone, and there are a lot of patients that cannot pass a 2 millimeter stone, as Dr. Lin appropriately said. So there's a wide range of factors, along with the composition of the stone, that are the wild cards. And so having the versatility for shockwave and ureteroscopy and laser lithotripsy is a great it's a great advancement in urology. And that's, I do feel like ESWL, as it's been marketed, has not been made relevant to urologists coming out of medical school, or may not have been exposed to it. And it's a fascinating conversation that Vic and I were having before we went live, that with the advent of gaming generations ago, hand-eye coordination among young surgeons that might have played video games as a kid, older surgeons that are retiring now may not have played video games. And so the advent of ureteroscopy and laser lithotripsy was not as easy from a hand-eye coordination standpoint. And so they had just reverted more to ESWL and utilized ESWL scenarios more. The younger generation now is very inept with, I don't know if inept is the proper word, but they're very good at hand-eye coordination. And so ureteroscopy feels more natural to them, and they're more involved in the procedure, where in ESWL, they're more of a mentor and more watching and giving advice. But I do feel like if ESWL could be marketed better in a scenario of learning, and the physician was actually more involved in the delivery of the treatment, that there may be more excitement for ESWL. But that's another episode for another day.
You know, Dr. Lin, yes, we called that out very early on in our slide. We didn't rely solely on self-reporting Rod's and our other highly experienced technologists' visualization. We did follow up with the urologists and said, so did it work? And yeah, it looks like they've passed. Again, the limitation of that is, and we're happy to drive the conversation within the shockwave lithotripsy business community. What defines success? Is it do we need an image 3 months later? Do we follow up directly with the patient? Because we've been prohibited by hospitals because we're under arrangement. Although we're the treating provider, it's the hospital and the urologist patient. So we have not directly contacted patients. We want to, and I think we'll get there as part of our quality assurance with their satisfaction and pain levels and complications. Instead of annoying the physician's office and their office staff, is to be able to follow directly up with the patient and say, how did it go? And so we welcome that discussion in helping define true success. We don't think 99% is that unbelievable, because when Dornier did their study for the FDA, they were at 92%. And in discussing with Eller Techs, we are seeing that success rates, meaning no additional treatment required in several months, is in the low to mid 90s. So we started a Facebook group to start to try to find more data. We've got about 140 technologists and healthcare professionals on that group now. So we're eager to really start benchmarking and improving shockwave lithotripsy across all entities. So your point is spot on, and we're looking to really come up with better ways to validate success. Appreciate that.
You mentioned patient selection as being one of the drivers, and better equipment, the more recent advances helping. Have you been involved at all in any production of patient education? I mean, know that from my own standpoint, of course, we treat patients ourselves, and the patient education component is really important, that they increase their fluids to help to pass the stone. Inversion therapy, where they're, getting sometimes on an angle to help to get some of those stone fragments that may be caught in a calyx out. I had a patient once come in that was not passing the fragments, and what her wife did is actually got a hand vibrator, like for muscle pain, and was vibrating with that. And believe it or not, the patient comes in next trip and they got this cup full of fragments. So I think patient education is one of those areas. And I know since they're really like technically your patients, but is that something you've looked in or thought about?
Well, again, they're our patient for 45 minutes while they're asleep. That's pretty much the extent of our involvement. We're looking to grow that. We are starting a podcast to help educate the general public and kidney stone patients regarding things like that. And I will say our urologist that uses us the most encourages his patients to, go on a bumpy ride. Go drive down a gravel road, and that hopefully will help you pass your stone. So yeah, we're very interested in expanding knowledge to patients, and this webinar is actually kind of the first step in that whole process.
Yeah,
I think there's a lot of confusion and sometimes misinformation about stents and stenting, and I had a long discussion with a urologist on Thursday about it. And if the stent is there to keep the ureter from being compromised with obstruction, and so a lot of times if the patient is stented and then you break up the stone, and then the fragments don't pass because the stent is still in place, there's several factors that Dr. Lynn could probably speak to better than I could, but the pressure needs to be applied by the kidney to push the fragments out, and the stent keeps the pressure from building up, right? Which so you don't have pain. It also, there's some dilation that happens over time, where the stent will dilate the ureter to be bigger, and then once that stent comes out, then those fragments probably have an easier time coming wafting out. And so maybe there's some frustrations from patients that are uncomfortable with the stent and don't grasp the concept that, you know, maybe those fragments aren't going to pass until that stent comes out. And but you know, and also we haven't really talked about post procedure imaging, and you know, there is some thought that a post ESWL CT would be the benchmark for validation of complete stone-free scenarios. But again, that's a big cost, and it's also a big dose of radiation. That is the trade-off. Is it worth it to know that the patient is completely stone-free? And so, I mean, that's something that is kind of a wild card to not being able to. I mean, if we could scan every patient post ESWL and know the level of fragmentation and the stone-free rates, that would be ideal. But obviously, there are challenges to that.
Lori, I see a couple comments came in. Can you share those?
Sure. So Nancy said, "Congrats on your entrepreneurship." And Nancy said, "Swimming is a great way to pass sand fragments."
I've also heard heating pads. Heating pads are also a great relief.
Yeah.
There was a study about what Russ talked about driving on a gravel road. There was some correlation in a study, kind of a novel study about riding roller coasters and people becoming colicky after riding roller coasters or passing fragments, which was kind of an interesting concept.
Imagine the N in that study wasn't that high.
You'd be sure to do it on the Eagle in Great America, because that thing is so rickety that
that'll shake a stone for sure.
I moonlight as a CT tech at a facility in the Northwest here, and I have had some patients come in that a patient went snow skiing and his back was sore, and his wife got one of the devices that Vic was talking about on his back, and then in the middle of the night, he woke up with horrible colic and came to the ER. And so, you know, if you think about it, she probably sent that stone. You know, he was having back pain from snowboarding or whatever, and then she sent that stone down the collecting system and there is a new technology called burst wave that is kind of being developed here in the Northwest. It's a very intriguing concept, and it's basically low energy vibration to help pass the stone down the ureter. And so that's a fascinating thing to keep tracking.
Great.
Although there are emerging technologies to move stones using ultrasound technology, I would caution everyone on these anecdotal suggestions on manipulating stones post ESWL, such as riding in a bumpy car ride, or using the low intensity, non-specific shockwave or vibrating machines on the outside of the body to try to pass fragments. The question I always ask myself is, what if nothing was done? Would that have also resulted in colic and subsequent passage of the stone? So that's something, when you are researching a topic, you always have to think about doing something and then versus the control. So there are a lot of anecdotes out there, but I caution the viewer and the listener that not everything that you hear will work or may work, and data collection and research is difficult, as illustrated by Rod and company here today. It's not as easy to answer a relatively simple question.
Absolutely. Well, very good. I don't see other comments coming through, so I think we're going to wrap it up. Been a great show. Really enjoyed having you guys on.
Thank you. Appreciate it.
I am going to put a plug in for next week's show.
Exploring sacral neuromodulation represents a frontier in medical science. Sacral neuromodulation involves the targeted modulation of sacral nerves through electrical impulses, thereby regulating bladder, bowel, and pelvic floor function. This innovative therapy has revolutionized the treatment landscape for conditions like urinary incontinence, overactive bladder, fecal incontinence, and pelvic pain syndromes, which can significantly impair quality of life. By implanting a small device near the sacral nerves, clinicians can deliver controlled electrical stimulation, effectively modulating nerve activity and restoring proper pelvic function. The procedure is minimally invasive, with many patients experiencing significant improvements in symptoms and overall well-being. Join us next week on euronurse.com to learn more.
All right. So I guess I got to put myself in the front. There we go. Thanks everybody for joining us this week, and join us next week for that other fascinating discussion on sacral nerve stimulation. It's going to be Dean Alterman who's joining us. Dr. Dean Alterman, who spoke about Optilume before, is going to be talking on that. So we look forward to that great discussion, and join us next week. It's always been a great trip with all you guys. And thanks for all your help to all of my great experts, and we'll see you all next week.